Hi everyone and welcome to Atp Live Monday. Uh, how has your day been? I hope you've had a lovely Monday. Welcome to Atp Live Monday from whichever platform you are joining us. This is Ask the Pediatricians Foundation Live Monday. I am Bimi Solaboide and I'm a pediatrician, and it's my pleasure to be with you all this Monday. For those who are joining us for the first time, this is one of our programs where you get to ask us any questions you may have about the health of your children in the next 1 hour, and we'll try and answer them live and direct. But remember that even after the live session, you can always see ask your questions on our Facebook groups. From Mondays to Saturday, we always have people there who will answer your questions. So thank you so much for joining us today. And the first thing I'm going to do is to share the video. So welcome everyone. If you're joining us on Instagram, on Facebook, on YouTube, you're welcome. You're welcome. Just drop a comment. Let's know you're there. And I'm just going to go ahead and share the videos to all our various groups. So just give me 1 minute to do all the sharing and all the pinning. But while we're doing that, if you have your questions, you can start to answer, drop your questions on the page. So welcome. So I'm just going to do my sharing now, and then we will be able to start. Okay, I'm sharing to our groups. We have 4 major groups. Though the most popular one is Ask the Pediatricians Facebook group, which is for our children questions. But we also actually have ATP Family, where you can ask your questions that are related to adult health issues. So there are so many of our groups that you can engage with. Okay, so just 1 more minute to do all the pinning, and then we're ready to go. Welcome to ATP Live Monday. Okay, thank you for those who are joining us. I can see you. Those who are joining us on Instagram, I can see you as well. Welcome to ATP Live Monday. I'm just doing the sharing and the pinning of the post, and then we are good to go. Just another couple of minutes and I will be done. And then we can start to answer your questions. Okay, I think I'm done with all the sharing, then just the pinning. Because some people will say, "Oh, I didn't know you were live. I didn't say it." So this is just opportunity for us to pin it for people to see. Okay, I think I'm done with all the sharing. Just one more pin. Okay. Okay, yeah, found it. All right, good. So I'm done with all the sharing and all the pinning, and so everybody can see and everybody can hear me. So once again, welcome to ATP Live Monday. I am Baby Salaboide. I'm a pediatrician, and it's my pleasure to be here this evening. This program is brought to you by Ask the Pediatricians Foundation. Ask the Pediatrician Foundation is a non-profit organization committed to the health and to the welfare of all children globally, but especially in sub-Saharan Africa and Nigeria, where most of our children uh, are dying from preventable causes. So we do a lot of online and offline advocacy and outreaches to empower parents so that our children will live and not die. So ATP Live Monday is just one of our programs. So where you get to ask the pediatrician live and direct your questions. So ask your questions. I'll be here for the next 60 minutes, maybe 55 minutes now, and then we're going to be able to answer your questions. So welcome, welcome, Pierre. Okay, good evening. Thank you so much for joining us. Remember, when you're asking your questions, start with the age of the child. Okay, pediatrics, we have children from 0 to 18 years, so there's a lot of difference between these children, so we always need to know the age of the child. Then tell us the summary, a brief summary, okay, of your concerns about the child, and then ask your specific questions and we'll try and answer them. So welcome. If you are watching on Instagram, or you're watching on YouTube, or you're watching from our Facebook page, you can just drop your questions live just under the comments, section of the video, and I will see your questions straight away. But if you're watching from our Facebook groups, remember that or any of the other groups that have allowed the video to be shared into, remember that you need to click on the video itself so that you can get to the comments under the video directly. That is where you need to drop your question, because sometimes people just drop their comments in the groups, and we will not be able to see it in the live session. But if you click on the video, then you drop your comments, I'll be able to see it live and direct. So welcome everyone, and welcome to ATP Live Monday. All right, I think I've done with all the announcements. Okay, so welcome. While I'm waiting for us to drop our questions, I will just talk to us a little bit about asthma, because I think tomorrow is the World Asthma Day. I think it is the 5th of May. Let me just confirm that. Either the 5th or the 6th. I know one is the World Kidney Day and one is the World Asthma Day, so that we can talk about it. Okay, yeah, so tomorrow, I was right. So Tuesday, the 5th of May, is the World Asthma Day. So if you have questions, feel free to drop your questions on any issue, any topic, and I'm going to answer them. But while I'm waiting for people to still drop their questions, welcome Ashiwaju Umu Ashraf. Welcome. Thank you for joining us. So while I'm waiting for her to drop our questions, I'm just going to give a little bit of health talk about asthma. Okay, so asthma, many of us are quite familiar with asthma. Asthma is actually the most common respiratory condition in children. And majority of children, really in the school age range, can have asthma. So asthma is quite common. I'm sure all of us know somebody who has asthma. All of us have watched movies where somebody needs to use the inhaler, maybe because they didn't get the inhaler on time, maybe they died. And some of us, I'm sure, may have heard of people who die from severe asthma and all that. So asthma is quite common, and that is why there's a World Asthma Day, which is a day for us to talk about asthma and to create awareness about asthma, and that is going to be tomorrow. But since I'm not going to be here tomorrow, I'm just going to talk about it today. But while I'm talking, feel free to drop your question. Now, I want to start by saying, okay, there's a question on the group. Okay, Pearl is asking whether does ATP group, that is our adults group, has a live session like this. We actually used to have it. We used to have that, but I guess we stopped doing it after a while because our doctors are quite busy. So it's actually take a lot of planning, a lot of time to actually come online and all that. So because of that, we stop having the live session for the adults, but we do post like recorded videos or some teachings, like Dr. Jumoke has done some live session, Dr. Rotimi as well. So there may be some that's already there that you can watch, but they don't have a live Q&A session like what we're doing now for the adults. We don't, unfortunately. Hopefully, maybe in future we can restart it again, but we've stopped it for a while, so that's just that. Okay. um and I try to abide in my calling, so I always stick with my pediatric questions. Okay, thank you for that. All right, Umu is asking, my 5 weeks old baby has rashes on his body and face. I want to ask if the rashes is normal it rash. Okay, thank you so much, Umu, for your question. And it's a very difficult question to ask because I really need to see that rash before I can say whether they are itch rashes or not itch rashes. So there are many different kind of rashes that can happen in babies, especially babies are just around newborn age. Your baby is just over 1 week over the newborn period, so practically still a newborn. So there are different kind of rashes we can have in newborn babies or very young babies. There are rashes that they are mild issues and don't require any treatment. I don't think we can actually say any rash is normal, but I understand what you mean. So what we mean is like this is something that is nothing to worry about and all that. So we have so many kind of rashes like that that newborn babies can have, and it's just nothing to be done. So each rashes will come under that. We call that malaria, and we also have what we call milia, where the babies have what look like white dots all over their face, when they are just born. So that is milia, and most of those ones you don't need to do anything. Whereas the itch rash look like there's a little bit of water inside or a little bit of redness, but you can see a little bit of swelling and dots. I'm sure most of us have seen itch rashes. So that is also common. Again, we don't need to do anything. Most babies have itch rashes because we tend to overwrap, overcover them and all that. So I always tell parents, let there be ventilation in the room. The room does not have to be boiling hot because of the newborn baby. I understand that we don't want the newborn baby to get cold, but I think we always go to the extreme, and now they are so hot, they are sweaty, and then that is why they develop itch rashes. Okay, but there are other kind of rashes that are serious in newborn babies. So newborn babies can easily get infection on their skin. So those rashes tend to look like a little bit of swelling with some yellow water inside, like pus inside, like we call it septic rashes. So most of those ones are from the hands of people touching the baby. So it is important that we wash our hands before we touch babies. Unfortunately, people culturally, when people come to greet the newborn, the new mom, everybody wants to touch the baby, everybody wants to carry the baby, and most people are coming with their hands that have not been washed. Those hands are carrying lots of germs, bacteria, viruses, and it's not bothering them because you don't see anything on the front of them, but those microorganisms and germs are on our hands. So when we touch babies, and babies are still very fragile, very sensitive skin and all that. So when we touch them without washing our hands, we deposit those germs, and those germs can enter into the skin of the babies and cause those skin infection. We call them septic spots. So you see it all over the baby. So what I always tell new people that go visit new moms, please wash your hands. And I always tell mothers, tell them to wash their hands or give them hand sanitizer at least for them to put on their hands before they carry the baby. Or best still, don't carry newborn babies when you go to visit. Actually, the person you went to visit is a mom. The baby doesn't need your visit because the baby doesn't yet recognize anyone. So the mom, I always tell mothers, you can leave your baby in your room, you can leave your baby in the baby, bed or net or whatever that is sealed up. The cords, the baby can be there, but people don't need to be touching or carrying the baby or sneezing on the baby or kissing the baby. They don't need to do that because all those things, I know they are signs of affection culturally, but they are depositing germs on the newborn baby who does not have so much immune system to fight those infections. Okay, so newborn babies don't need people touching them, carrying them. The person that should be touching the newborn babies, usually the mother and those who are helping the mothers. And you know that mothers, in the process of taking care of the baby, they're always washing their hands, they're changing nappies, they're washing their hands, they're bathing the baby, they're washing their hands, they are making new food, they are always washing their hands. So mothers invariably are always washing their hands. In fact, in Yoruba culture, we greet a new mom by saying Eku owo lomi. Ekwawolomi means you're always putting your hand inside water. So even the culture recognizes that a new mom is always putting her hand inside water. So she's always washing her hands. But the people that are coming to visit, they have not been washing their hands. So most of them just come and touch the baby and they deposit germs on the baby. And that can cause skin infection. So that's one thing that can cause rashes in newborn babies. Another thing is that babies react to all these products. Some of us, all these nice baby care products, they smell so nice, but most time babies are actually allergic to all those chemicals because all those things that are smelling nice are chemicals. And some babies have, this sensitive skin and they can react to those chemicals. So, which is why we normally recommend that you don't use all these sweet smelling products on babies. Use natural products, your Vaseline, Blue Seal without perfume, your Ori, shea butter, you know, natural products. Those are better. Your oil, coconut oil, olive oil, those are okay. So, but some of these nice, sweet smelling stuff that we like to use on our babies, they actually make babies react to them, and sometimes the baby can have rashes from the allergic reaction to those products. In fact, there's a recent time somebody was asking about baby cologne, and I like, seriously, when did baby need cologne? Baby already have their own nice smell, very lovely sweet smell of babies. They don't need any extra cologne. They don't need any extra perfume. So just make sure you wash them, keep them clean, use natural products, and they'll be fine. So for Umu, if you are still listening to me, you need we need to see this rashes. So I would recommend you can take a nice picture of the rash. Please wear clothes for the babies. People always take pictures of babies and they always take pictures naked. I don't know why. Babies also have a right to their privacy. So please wear nappies for them. At least wear a nappy, before you take a picture. Minimum. If the area you are showing is not the chest area or the abdomen, you can actually wear a vest as well. But if you are showing the chest and all those areas that need us to see, then you can just wear the nappies, but don't show their genitals, okay? Respect our baby's privacy. So you can take a picture of that and post it on our Facebook group, and then I will have to look at it and we can quickly tell you whether it is one of those mild skin rashes that you don't need to do anything, like itch rash, like melia, or even acne and all those ones, or it is an infection, or it's something that look like an allergic reaction to something. So we can advise you further. But if you don't want to also post your baby's picture on our Facebook group, you can actually take the baby to see one of our doctors or nurses in the hospital, and then they can have a look and advise you further. But one thing I'm going to advise is that don't start using any products on that baby's skin. A lot of Okay, Umu said you have posted on our Facebook group. Lovely. So I will get to it because most of the time it's the pediatrician that will have to answer that question. And I'm here now, so I've not gone to the Facebook, but don't worry, I'm sure we'll get to it soon. Okay, so that's fine. So we will have a look and then we'll get back to you. But while you're waiting for us to get back to you, please don't use any product on the baby's skin as a treatment. I know a lot of the what we call them, our experienced mothers, they will come and tell you, oh, this rash, go and use this one, go and use that one. Please don't. Actually, it's better to do nothing than to do something that will make things worse. And sometimes most of the things we do when it comes to rashes, they actually make things worse. Okay, so don't use any of the triple action creams. Don't use any other products. Sometimes, like I said, some rashes require that you don't do anything. Why some rashes actually require that you stop doing something you are doing. So, but people say go and buy this, go and buy that. No, please avoid that. just leave it alone first until you get the professional advice on whether you should do something or you should do nothing. And so I hope that is clear. So a lot of mothers ask questions like, oh, I'm using a particular product. I don't want to mention the name because I don't want to advertise for them, but you all know the product that you all use. It's like, see if that is the go-to for treatment of skin rashes, and mothers always like to use, I don't know what advertisement the company did, but all the mothers seem to believe that if a baby has a rash, just go to that particular product and all the rashes are gone. That is not true. There is no one product that kind of cure all the skin rashes or that can take care of all rashes. So like I've explained, depending on the cause of the rash, that's what will determine whether, number one, we need to even treat it or we don't need to treat it, or whether it's actually that we need to stop doing something. For example, if your child is reacting to the cream or the oil or the lotion you are using, the solution is just to stop the product. So you don't even need to do anything. But if it's a child having like um allergic reaction to something, you need to stop that product. But if it's a child is having like an infection, then the treatment will be an antibiotic. We also have fungal infection, the treatment will be an antifungal. So most of the time there is one specific treatment or no treatment at all for a specific rash. So there is no way one single product will kind of cover everything. So that is just the idea behind that. So I'm always kind of when I see mothers say, I've used this product, I'm like, you don't even know what the rash is. So how did you know what to use and why have you used that product? What if the child is not allergic to this particular product and that is actually going to make things worse? So I'm happy you've posted it on the group, but just give us a little bit of time and then we will get to it and then address the issue. All right. Thank you so much for that. I don't think I have any questions on Instagram. Instagram people, you're welcome. If you have any question, please post your questions directly on the comment section and I will answer them. All right. I was talking about World Asthma Day, which is going to be tomorrow. And I've already told us that asthma is the most common condition that has to do with respiration or the lungs in children. So it's something we should all know about. And I'm sure every one of us have seen somebody who is using an inhaler. So asthma happens in children. So it is not just adults that have asthma. Children actually have asthma as well, actually the school age children. Okay, so that is the first thing. So what is asthma? What really happens in asthma is that the way we breathe, we all need our hair, going to our lungs. So we have what we call the hair, the respiratory system. You start from your nostrils, it goes down to the back of the throat, what we call the pharynx, and it goes down to the trachea, and then the trachea, the windpipe, it will break into two, and we have what we call the bronchi. That's the large airway, and then those bronchi break also into like tiny branches, just like trees, and then you have the bronchioles, and then before it enters into the lung. So those are the way air goes from our nostrils down to our lungs. Now, if there's any breathing that causes those, especially the tiny parts of those airways, as it's getting lower, what we call the lower airway, because so we break the airways into two parts. We have the upper airway and we have the lower airway. So the upper airway, starting from your nostrils down to the trachea, and then the big two branches bronchi, and then but once you start getting smaller, we call them the lower part of the airway. Now those lower parts of the airway, they are very narrow indeed, and but if anything happens that blocks them, it will narrow it further, and when it narrows further, it will be difficult for hair to come out of it. So hair is going in, we inspire hair, and then we also expire, we bring out hair. So what happened in asthma is that there is what we call inflammation. There is swelling and a little bit of mucus, a little bit of something in the airway, and it kind of narrow those lower uh, airways, those lower branches, bronchioles, and that is, and then it's making it difficult for hair to go out. So when the hair is coming out, there's a lot of noise. You hear what we call the wheezing, like a wheeze. And that is what normally happens in asthma. So that is just a little bit of a layman description of what is going on in asthma. So some people just have that tendency for that their own airway to be blocked when they are exposed to certain things. So there's number one. So in asthma, there's a genetic tendency. So asthma tends to run in family. So one of the questions doctors always ask us is there anybody in your family who has asthma? Especially the mother side, it tends to run through the mother side. So if a mother has asthma or any of those other allergic conditions, because asthma is also one of the allergic or what we call atopic conditions, those people have that tendency to react to certain things. And the way they react to those things in asthma is there will be swelling, there will be inflammation of the lower airway, and that will block it. And then the person will begin to struggle to actually bring out the hair. And then you start hearing them having what we call wheezing. So that is very common thing in asthma. So number one, there's a genetic tendency. Then there are certain things that those people, when they're exposed to it, they begin to have that reaction, and then the hair will start to get blocked. So, and there could be anything. Some people react to the cold hair, even just the hair being cold. So during cold season, some people react to pollens, in the, during the like spring, and there's a lot of, the trees are shedding their pollens and stuff like that. Some people react to dust, even like people just sweeping the house and there's a lot of dust. And some people react to the animals danders, when animals are, if you have pets in your house, they will shed their skin and all that. So some people can be allergic to that. And if they have, so when they're exposed to any of, even perfume, some children are allergic to perfume, and that's why most pediatricians will try not to wear very heavy perfumes in the hospital, because you can have a child who has asthma in your clinic. So it can trigger off that what we call asthmatic episode or acute severe asthma, and the person begin to wheeze and the hair will begin to narrow. But the good thing about asthma is that that narrowing of the airway, that blocking of the airway, is reversible. It is reversible. So in other words, it will swell up, block, and the person may struggle to bring out the hair, but after a while it will kind of expand again. So, and then the person will feel better. But sometimes if the swelling is so bad, it can actually cause death, if it's very severe. So asthma can be quite severe, because at that point, hair is not going in, hair is not coming out. It's a very dangerous place to be. And so what we normally do in treating asthma is we want to dilate, we want to open up that airway. So which is why we use things like inhalers. So most of those inhalers, their job is that when people, breathe in the medication with what we call the bronchodilators in the inhalers, it helps to open up those airways, and the children or even the adult, they can breathe and allow air to go in and out. But that is always a temporary thing. But the long-term treatment is to work on what is causing that inflammation itself, what is making the underlying reason why the thing is swelling and there's a lot of inflammation. So in addition to the what opens the airway to expand the airway, we also have to give medication. We call it anti-inflammatory medication to reduce the inflammation and to reduce all those swelling. And most of the time we tend to use steroids for that. So that is why treatment for asthma, there are two things always combined: something to open the airway, the bronchodilator, and something to reduce the inflammation, usually the steroids. So that is just a brief explanation of what is going on in children who have asthma. So if you have questions, feel free to ask. So I'm just waiting for people to ask questions. But since people have not asked any question, I will continue my teaching on asthma. So, at what age can children start to have asthma? Some people, they can start having asthma even as newborns. It's a little bit tricky at that age, but it's possible. But we tend not to diagnose asthma until after the age of 1 year, because usually before the age of 1 year, children can have viral infection that can mimic asthma. So we call it bronchiolitis. So babies, infants, they will, when they have all this respiratory infection, usually from viruses, they tend to have their wheezing sound. You start seeing them, having respiratory distress, and you hear that wheezing sound. I'm very poor at mimicking things, but you start hearing the sound. It's a fine, tuneful sound, they will start hearing the wheezing. And so if it is happening in a baby less than 1 year, we tend to go for what we call bronchiolitis, because at that time we may not be able to separate bronchiolitis from the asthma. But if it happens again, because bronchiolitis tends to happen maybe once and that is it, and we know the child was having a viral infection. But if a child continue to have recurrent, because that is another key thing in asthma, is recurrent and is reversible airway, chronic airway obstruction. So for people who have asthma, it won't happen once, it will happen again. Okay. So if it happened the second time and we were able to reverse that wheezing and that obstruction with those drugs that I call bronchodilator, then, and especially also if there's a family history already of asthma, then we can say this person is likely asthmatic. So most doctors are reluctant to put the label before the age of 2 years, but most time, if it is recurrent, even from age of 1 year, we can give a diagnosis of asthma, especially if there's a strong family history, because like I said, it is the underlying thing is genetic. And then when the person is exposed to certain things, they start to have the wheezing, and they will feel better after a while because it's a reversible process, but it is recurrent. So it will happen again and again. So that is how we make diagnosis of asthma and separate it from bronchiolitis. We tend to diagnose bronchiolitis in the under one, and we try not to go for asthma in that age group. But by the time you start getting to over one and the child is having recurrent wheezing, recurrent respiratory distress with wheezing, then that could be asthma. Also, some children also is cough. They just cough a lot and they tend to cough a lot at night. That could also be a pointer to asthma. Some children, exercise is what induce their own asthma. So once they do a little bit of running around, a little bit of activity, then you start seeing them breathing fast and wheezing. That could be asthma. Some children, like I said, it could be dust. Some children, it could be perfume. It could be many things. Some children, we don't even know what triggers their own asthmatic episode. Sometimes even the airway pollution, especially if you live in areas where there's a lot of industries and manufacturing industry, they are releasing a lot of all these gases into the air. It could also trigger asthma. There was a time in Port Harcourt that parents were telling me there was a lot of black thing that was suits, like it's all over the hair in Port Harcourt. I hope it has resolved really, because that can trigger off asthmatic attacks in people who have the genetic tendency for asthma. Okay, so that is just definition and causes of asthma and the presentation of asthma. Now, asthma can be mild. So some people will have the asthma episode maybe once in 1 year or once in 2 years. So it's very few, far and in between. Some of them don't even remember the asthmatic, and they may not even have the inhalers. So that is mild one. But some people have what we call or we call them intermittent asthma. But we also have people who have asthma frequently, maybe every month there will be something. Okay, so you have people who have it every month, you have people who have it every week, you have people who are having it almost every day. So it can be mild, it could be moderate, it could be severe. Okay, that is the asthma itself. Then each episode of asthma itself can be mild, moderate, and severe as well. So there's the asthma in terms of how often do you have symptoms. And then there is each episode of the asthma itself. So in other words, even for somebody who doesn't have asthma, maybe who have asthma once in a year, the first episode they may have an episode that could be quite severe and may land in the hospital. So that people that will have asthma attack, acute severe asthma, and it's an emergency, we are taking them to the hospital, we're putting them on oxygen, and they are in the hospital. And there are people that have the mild attack, they just use the inhaler and they feel better. So there are different kind of episodes of asthma. So but for people who have the chronic asthma that tends to happen even if it's once a week, once a month, we have to put them on medication. For people who don't have asthma of maybe once in a year, maybe only when they're exposed to something, we don't put them on regular medication, but we always recommend that they have their inhalers so that whenever they have an attack, they can quickly give themselves treatment. Actually, asthma is one condition where we allow you to do self-medication. I know most of the time we always say, oh, we frown on self-medication, and all that. And many people are quite familiar with that. But to the honest truth, the asthma is the exception to that rule. Asthma is that condition where we actually allow you to do self-medication because we can't. It's important that you address it quickly, otherwise it may be too late. And we've seen people die from asthma, and we've seen prominent Nigerians, I'm not going to mention names, but we've seen prominent people who die from asthma because they have an acute episode, very severe episode, and they were not able to get them to the hospital on time, and it can lead to that. So we've have, at least I remember 2 cases growing up, very prominent people. So that is why asthma is something that we allow you to do self-medication. So if you're having an asthma attack, we allow you to have your inhalers. We allow you to use your inhaler without your doctor's prescription. We actually have what we call an asthma plan. In other words, once you start having symptoms, this is what you should do. And we allow parents, for children, we allow parents to also manage their asthma. We allow parents to give children their medication once they start having symptoms. And if they've done it, they've given them their inhalers and the children are not better, you have to bring them to the hospital. Because like I said, sometimes we need to give them steroids. We need to give them, some children have severe asthma that we have to give them oxygen because their oxygen level is dropping. And sometimes it can be severe enough that all those medications are not working and we need to take the child to the ICU. So asthma can be deadly, can be sinister, and it can cause death. But luckily, we don't tend to have a lot of children having that severe type. Most children, they have the mild one. You give them an inhaler, they feel better. But it's also important that if a child is having the chronic asthma, they are taking regular medication. So there are inhalers that we give them every day to prevent them from having symptoms. So we call those preventer, very easy to remember. We call them preventer medication. So those are the medication that the children have to take every day, first to prevent asthma attack. But when they have an asthma attack, we now give them another kind of inhaler to stop the attack or to control the attack. We call those one controllers. Those are the inhalers that most people are familiar with, like your Ventolin, your Salbutamol, But these days, it's often recommended that we should give both treatments at the same time. Even for those who are having an attack, you give them the bronchodilators, but you also give them steroids as well, so as to quickly get the symptoms under control. So that is asthma. So it's important for you to know if your child has asthma or not. I know a lot of parents, actually in Africa, it is a stigma. It's one of those conditions that we put a lot of stigma on. It's just like epilepsy. Asthma is another one. A lot of parents don't want to label their children asthmatic. So I see a lot of questions, and parents will go round and round and round, and then they will come to this father, oh, there's nobody asthmatic in my family. Even though they've told me everything I need to make a diagnosis of asthma, but because they don't want that label, and they will say, oh, there's nobody who is asthmatic in my family. So, and I'm like, it doesn't have to be there's family history. It can start with the child. So why is it so important that we put a label on it? Because if you don't put a label on it, you won't treat it properly. you won't treat it properly. Oh, somebody is commenting from YouTube. I always like people listening from YouTube. Thank you, Juliana Muturayo. I'm very happy to have somebody from YouTube commented. All right, so a lot of parents worry about the level of asthma, but let me just tell you the good news first before I tell children can actually stop having the asthma episodes, so they can outgrow their asthma, so to say. That's the our popular Nigerian phrase, though, can the child outgrow it? Yes. Basically, the child can stop having symptoms. So some children by the age of 5 years, although some children will have a lot of asthma attack as from 1 to 4, but by 5 they just stop. Lovely. But some people will continue to have asthma as adults. In other words, it will be permanent in their life. So that is number one. Then number two is the fact that asthma is not a contagious disease. So you don't get asthma by staying with somebody who has asthma. You don't get asthma by being a friend of somebody who has asthma. The fact that they are breathing or coughing near you does not give you asthma at all. So you don't need to panic. You don't say, don't share my. It is not like HIV. It's not Ebola. It is not COVID kind of condition. It's a genetic condition. The person has that tendency that they are born, and and when they're exposed to what we call the triggers, those conditions that tend to stir up an episode, they can have symptoms. So it is not something you get from people. You are born with the genetic changes in you already that make you to be prone to having asthma. Having said that, even though you have the genetic tendency, you are not likely going to have asthma if you don't get exposed to the triggers. Actually, if we know the triggers, so the most important thing for parents is to know what are the things that will make my child to start having attacks and to avoid it. So this is one of the things we tell parents. So sometimes I know when we were growing up, it's compulsory for some children, for us as students to sweep the school and do all the work and all that. And sometimes we have had to write to schools and tell them that this child has to be exempted from sweeping the classroom because this child is asthmatic. So they cannot sweep because dust can trigger off asthma. They cannot do farm work because cutting the grasses will trigger off an asthmatic attack in them. Luckily, we are living in a generation where most of our children go to private schools and the schools have their own cleaners and people will do all those work. So children don't end up doing all those work. But in those days, we used to actually write to schools to exempt children. So parents have to make sure you know what trigger your child asthma and avoid it. So, for example, if you know your child get triggered by your perfume, one of the loving sacrifice you have to make for them is not to use a perfume because they're going to have an asthmatic attack, just by your perfume alone. And dust, so we usually recommend those who have asthma, we don't recommend they use rugs. We don't want them using rug because rug tends to accumulate dust. So we recommend you use the normal carpets, the linoleum, those ones that you can just mop with water and it will be clean, or tiles. We don't want you using rug because those rugs generate a lot of dust and absorb danders of animals, pets, and stuff, and that can trigger asthmatic attack. So people who have asthma tend to have um, towels or carpets that can be mopped with water. Number one, you don't want dust. We don't want a lot of fluffy stuff. We don't want them walking through grasses if it's a trigger for them. We don't want them going to places that are dusty. Some children get their asthmatic attack by exercise. So sometimes we exempt them from PE as well. So we tell them they can do PE. So if we know the trigger for the child, we are going to have to exempt the child from the triggers. And we want you to live in areas that are clean. Rural areas are actually the best for people who are asthmatic, because some of the industrial areas, air pollution is a major issue. So you don't want to live in industrial area where there are lots of air pollution and all that. We want to avoid that. We want to avoid cooking with firewood, even the firewood smoke, even burning bushes, burning things around the house, even frying palm oil. And those of us in Africa that like our fried stew with palm oil, you in a child with asthma, you want to avoid all that because those are things that can trigger asthma episodes. So as much as possible, we want to avoid the triggers. And in addition to avoiding triggers, we want to give the children regular medication. This medication, sometimes the children have to take it every day. It's just like epilepsy. I think asthma one is a little bit worse than epilepsy, because in epilepsy, after 2 years, if the child is no longer having symptoms, we try to tail off the medication. But for the asthmatic people, they tend to be on their medication almost for life, especially if they are the type that have the chronic, moderate, severe asthma attack. For those who have intermittent symptoms, maybe once in a year, we don't put those ones on regular medications. So yeah, and then of course you must always have your inhalers always around you, because the attack can happen anytime and you must be prepared. And in addition, sometimes we also give some other anti-allergy medication, depending on the level of severity of the asthma. But just for you to know that for children, we have the asthma clinic for children in most of our teaching hospitals and general hospitals. It is important that your child is registered in those clinics. It is important that the child goes for regular checks, so that the pediatrician, they can check the children, and then they can always let you know, if they need to adjust the medication, form a plan. And one of the things we also try to do is also to get our teachers involved, because sometimes children have this episode in school and teachers must know what to do. In places, ideally, we should have school nurses, we should have our sick bay, we should have a nurse there, and the children should have their inhalers in the school. But most of the time, we don't have school nurses, we don't have sick bays in some of our schools. So the best thing is our teachers. Our teachers need to know what to do. So we normally write what we call a plan, asthma action plan. If a child who is asthmatic is having symptoms, this is what you do. This is not when you start pouring water on them. I don't know why we like to pour water on people who are having acute episode, whether they fainted or they're having seizures or they're having asthmatic attack. I don't know why in Nigeria people always think the first thing to do is to go and pour water on people. There is no medical emergencies that require anybody to have water poured on them. You can take that from me and take it home. There is no single medical emergency that you need to pour water on people. And so let's just stop that. I know it's Nollywood and movies that have taught us all that. One of the things we did in ATP, one of our projects we've done over the past 2-3 years, is actually to go to schools and teach our children basic first aid. And we actually give them our first aid booklets. I actually have a copy just near me now, but I can't find it anymore. But we actually give our children those first aid booklets. I'm sure if one of you in the comment section, we have a copy or your child has a copy. And we tell children what to do for every basic medical emergencies, including asthma. And so we don't pour water on people. We don't crowd them. They need oxygen and they're struggling to get the oxygen. Crowding around somebody who is having an asthmatic attack is actually going to make it worse. And we don't pour water on them, okay? What they need is the inhaler. So ask them, where's your inhaler? They should always have the inhaler on them. But we know children can be quite forgetful. So there should always be one in the school. The school must have an inhaler in the first aid box, okay? So that if a child is having an asthmatic attack, we just give them the inhaler. Most children from the age of 5 and 6, we can teach them to use their inhaler. But for children below the age of 5, between 1 and 4, they may not be able to use the what we call the meter dose inhalers, because there's a technique to using an inhaler. It's not just spraying it like perfume. You actually the children have to breathe in, they have to spray, and then they need to hold it down, breathe in that medication when they put the inhaler in their mouth with their mouth tightly sealed around it, and then hold it maybe for a minute and then gradually release the breath. So there is a way to do that. And so we need to teach our children that our babies, they cannot do that. We have what we call a spacer device. So a spacer device is a like a cylinder that we attach to the inhaler, and then we put a mask on it and put it on the child. So what that spacer does is to hold the medication for us, and the child can just breathe in and out until that medication is fully absorb into the system. So that is just that. I think I have a question. I'll come back to my asthma talk. Aguloye Olubunmi, good evening. So, what is the causes of lymph node behind baby's head? Joe, I took my baby to the hospital when I noticed it behind my baby's head. Doctor asked me to run MP full blood count, but it was only malaria. Malaria she said, but lymph node is still there, but not as big as it was before. Thank you. My baby's weight is 4 kilos. Current weight is 8.5. Baby is 10 months old. Lovely. Obviously, this is a mom who is an ATP mom. She knows all the things we always want. So, thank you. All right. Let me quickly answer Olubumi's question, and then we'll come back to asthma. Lymph nodes are normal structures in the body. Okay, they are like your hands and your legs and your teeth and your ears and your eyes. They are normal structures. So we all are lymph nodes in the body. We have them everywhere. We have them around the neck. We have them on our armpits. We have lymph nodes in almost every part of our body. Now, but they are very tiny, they're very small. So most time you may not even see them. Sometimes you can barely feel them, but they're always there. So lymph nodes are normal structures in the body. What does lymph nodes do? Lymph nodes tend to run along the veins. So um, we have a lot of fluid in our body. We have the our blood. You know, we have the blood in the arteries, we have the blood in the veins. But another fluid we also have in our body, we call them lymphatic fluid, lymph. So that lymphatic fluid is the water inside the tissues. I'm trying to break it down and not use medical jargons. So those fluid is absorbed into the lymphatic channels. So they kind of drain all those fluids. Now, the lymph nodes are they produce what we call some some um they are parts of our immune system in a way that they help us to fight infection. So they produce some certain kind of blood cells, the white blood cells, the B and the T lymphocytes, that's what we call them. So that is their job. So they are part of the immune system. Let me just leave it at that. Okay. So whenever there is an infection in a child's body, the lymph nodes around that area, they begin to get bigger because they have to do more work. They have to produce more of those lymphocytes and all that, drain more fluid. So they get bigger, and then they can feel hot to touch. They can also feel painful, and they can also sometimes, depending on the kind of infection, they can even gum together and all that. So lymph nodes tend to get bigger for certain reasons. Okay, one of them is if there's infection around the area they drain. So if you have ear infection, the lymph nodes around the ear area may increase in size. If you have infection, around the neck area, the lymph nodes around the neck area may get bigger. So that is one time that lymph nodes get bigger. Sometimes in certain conditions like cancers, tumors, so the lymph nodes can get bigger as well. In certain infection like tuberculosis, they can get bigger and kind of stuck together. So there are different reasons why the lymph nodes can be big, but lymph nodes are common. They are normal structures. They help us as part of our immune system, but they get bigger when something is going on. Either the immune system is trying to fight infection, or the immune system itself is having issues, and there's multiplication and tumors and all that. But there are many of them. Those ones are rare, but the most common reason why our children lymph nodes get bigger is because of an infection. Okay, so, and you don't need to worry about it, because as the infection clears, the lymph node will get smaller. They will reduce in size back to the normal size. They may not completely go back, disappear completely. They may always be there, but as long as they are not getting bigger, and there are certain sizes that worries us, or also if they are not increasing in size and they are not increasing in number too much, we are not worried about it. But if they are getting bigger, they are increasing in number, and they are hard to touch, they are painful, they look red, then that is when we think there's something still going on, like the infection is still going on, and we need to treat the infection. Also, to treat the infection, then the lymph nodes will shrink back to their normal size. So, from your post, your child has a lymph node behind the head, and I suspect your child may have had an infection. The fact that you do a full blood count and it is normal does not rule out infection. It just means that maybe it's not a bacterial infection, it could have been a viral infection. So it is not every infection that shows up on a full blood count. Okay, so but if it's a viral infection, it means your doctor does not need to treat it anyway, so it will go down by itself. And from what you said, it's already smaller, so that is a good thing. So there's nothing for you to worry about. A lot of parents tend to fixate on it as if you want it to disappear completely. Just leave it alone. As long as it's not getting bigger, you don't need to worry about it, and you don't need to panic about it. So I hope that is helpful for you, Olubumi, as respect to lymph nodes. So just leave it alone, and your baby's weight is okay. 10 months, 8.5, lovely average weight, and we have nothing to worry about. Okay. All right. I got another question from Udrak. Good evening, doctor. My baby of 15 months started vomiting, stooling on Saturday night to Sunday. I call his doctor, who prescribed zinc tablets and ORS. Good. The stooling has stopped. Lovely. But since yesterday, he hasn't pulled. He has been fattening. Okay. The tummy still looks full of gas. What should I do to ease him? You don't need to do anything, but make sure you're giving the ORS. Make sure you're giving ORS. One of the complications or consequences of diarrhea is that the children can lose a lot of electrolytes. So when children are having diarrhea, one of the things we want you to give them ORS and not just ordinary water is that it's not only water that the child is losing. The child is also losing what we call electrolytes, salts. They are losing sodium, they are losing potassium, they are losing bicarbonate in the diarrhea. So if you give the child ordinary water, you are replacing the water, but you are not replacing the sodium, you're not replacing the potassium, you're not replacing the bicarbonate. And that can cause what we call electrolyte imbalance. Electrolyte imbalance is a major issue in children as a complication of diarrhea that has not been appropriately corrected. Okay. And the impression you're giving me, if your baby's tummy is full, distended, and the child is not passing stool, though the child is passing gas, which is good. So, but one of the things I will worry about is low potassium. So hypokalemia is something that can be going on here, and hypokalemia causes what we call paralytic ileus. In other words, the intestine not able to do their work properly, so there's no movement, so the tummy can get distended, and that can be a reason why the tummy is full and the child is not passing out the gas or the stool by itself. Because normally, if the potassium is there, the child will pass it out themselves, so you don't need to do anything. So you said the child is refusing to take the ORS. No, the child has to take ORS. So I'm worried that your child may have low potassium. All right, so ideally, what you may need to do is to go to your doctor now, and they may have to take the baby's blood and check the potassium level. So if the potassium is low, they may actually even have to correct the potassium, like admit the child and give the child potassium through the vein, or give the child tablets that can give potassium. The potassium, the bicarbonate, they are so important. Plain water is not going to be enough for diarrhea because the child has lost more than water. The child needs to take something that has sodium, that has potassium, that has bicarbonate, that have glucose. So you have to give the child. So there are many different kind of ORS. So we have the one that we have colored with orange juice. So we have the flavored one, we have the orange flavored, different flavor ORS. So if your child doesn't like the plain ORS, why not go and get the flavored ORS? So you can get the orange flavored. There are different kind of flavored ORS so out there. So, but the child needs to take one of those ORS, because I'm concerned that this child may have low potassium and this child may be going into what we call paralytic ileus, and that is not a good thing. It's not good for your potassium to be low, because low potassium, apart from affecting the intestine, it can affect the heart, it can affect so many organs. Potassium is one of the most important uh, electrolytes. So sodium, potassium, bicarbonate, they are very important, and we lose them when children are having diarrhea. So it's important that the child should drink the ORS. I know they don't like it, but they have to take it because they need it. So we can give the child other apart from ORS, there are other form of fluids as well that will have a little bit of some salt in them. You can even make sure you increase the salt in the food the child is eating. There are some fruits that if you give the child, you can also give them potassium. I'm trying to remember the name now. So prune, I think it's something around prune and all that. You can also give them potassium, but more importantly, the ORS is the easiest way to get potassium in your child's body. So I'm happy the child is still passing gas, so that's good, because when you go into complete paralytic ileus, even the child will not pass the gas at all. So what you need to do is to make sure the child drink ORS, eat normal food, and then the child may not have much stool to pass again, because after all, the child has been passing so much stool, and at times mothers will invariably stop feeding the children because they have been passing diarrhea. You shouldn't stop, you should keep feeding them. I'm just explaining why the child may have nothing much to pass, because the child is been passing so much, so there's little or nothing left in the intestine. But the gas distension worries me about paralytic ileus, so you really need to make sure the child drinks a lot of the ORS, so that will help correct that. If it's not getting better, please go to the hospital, see your doctor. They need to do the potassium level, they need to do what we call electrolytes and serum electrolytes for the child, so they will know the level of the potassium, and if it is low, they have to correct it. They have to give the child medication for the potassium. All right, but in the interim, what you can do as a mom is to be giving the ORS. Encourage the child to drink ORS. You can get the flavored one. That will be helpful. All right. Oh my goodness, it's already 7 p.m. I didn't even know. I talk a lot and I don't even know time has gone. So our time is up already. All right. Thank you so much, everyone, for watching. And I hope you've learned a bit about asthma. Please, the message I would like to pass is there's nothing wrong in a child being asthmatic. It's just like saying a child is short-sighted, like I am short-sighted. I'm wearing my glasses. The reason why I know parents don't like labels, but sometimes we have to label things so that we can get appropriate treatment for them, so that we can treat it. So that is just the only reason why we label them. So if your child is asthmatic, don't say it's not my portion and all that. I know we always say, but the most important thing is for us to see we have asthma clinic for children. In almost all the teaching hospitals, we have an asthma clinic for children. Some of the general hospitals have that. Make sure you go there. Let them evaluate your child. I didn't even talk about how we diagnose asthma, how we do the plaque flow meter and all that. But don't worry, when you go to the hospital, the doctors will do all that. And then, so if they make a diagnosis, then they will be able to tell you whether your child is having the intermittent asthma, which means the child just needs to have an inhaler for when they have episodes. But if the child is having the chronic kind of asthma, the child has to be on treatment, daily treatment. So please, it's important, because we don't want our children to have the severe asthma, because the reason why some children have the severe asthma is because they were not on treatment, and when they eventually have the asthma, it's quite severe. And like I said, we do lose children from asthma. Children can die from it, even though it's not common, but it can happen. So please and please use this opportunity of the World Asthma Day to make sure you get, actually if it runs in your family, make sure you get your child evaluated. So, and if you still have any questions about any of the other topic about, or any other health issues as far as our children are concerned, please kindly go to our Facebook group, Ask the Paediatrician Facebook group. We have a big Facebook group, over 700,000 people. Post your questions there. We are there from Mondays to Saturday. Yeah, Monday to Saturday, 24 hours daily to answer your question. Of course, we don't do emergencies, so just be patient. When you drop your questions, we may answer it in 24 hours, we may answer it in 48 hours, but be patient with us. If a child is sick, a child is having acute asthma, a child is having acute illness, please and please come and see us in the hospital. Don't leave that on the Facebook group. But if you just want to know all this knowledge kind of questions, what to do, what to prevent, and things like that, things that is not an emergency, the child is otherwise well, but you just want to know some things about the health or how to take good care of them, feel free to drop those kind of questions on our Facebook group and we will answer them. But if your child is acutely ill, please bring the child to us in the hospital. That is where you will catch us during the daytime. All right. So thank you so much. If you want to read more about all these topics, we've talked about asthma, we've talked about there's especially any topic you want to talk about that we've not talked about before in detail. So go to our podcast, Ask Dr. Gbemi ATP podcast, or go to our YouTube channel. Juliana, thank you for staying on our YouTube today. You can watch all our past videos on each of those individual topics there as well. And then even on our Facebook page, we don't delete our videos, but Facebook takes off the live videos nowadays. So, but they are always going to be on our YouTube channel, so you can watch them. And if you're the type that you like to read, we've also written articles on all these topics on diarrhea, on bronchial asthma. There are articles on our website, www.askthepaediatricians.com. So thank you so much. It was my pleasure to be here, and I'll see you same time next week, God willing. Before then, have a wonderful, wonderful rest of your week. Bye bye.